Hey, good morning, everyone. Thank you for taking the time to join us this morning. We appreciate you being here. We wanted to take this opportunity as the holiday is coming upon us to just speak directly to the people of Alabama and to answer questions, if we can do that, about what we see taking place with respect to COVID. We wanted particularly to let you know what our concerns were about the upcoming holiday, given the numbers that we're having in the state. And then again, we'll certainly be willing to answer any questions you have about this or any other matter. Alabama is seeing its numbers go up, just like every other state in the country right now. We are not headed in the right direction. We are adding a couple of thousand new cases a day, at least, that we are aware of. Since this response began back in February in the United States, we have had more than 12 million cases of COVID-19 so far, and yet we are now adding about 1 million cases per week. So let me say that again. We've had more than 12,000 cases in about 9 months, but we added 1 million just last week alone. And the numbers seem to be continuing to head that way. There is unchecked spread of COVID-19 throughout most parts of the country and throughout many parts of Alabama as well. We have had more than 230,000 Alabamians that have been infected so far. I always want to remind you that those are not numbers of positive tests. Those are unique individuals, more than 230,000. So somewhere around 4% of our state has been infected so far. We have had hospitalization numbers that have been steadily increasing now for about 6 weeks. We have more than 1,300 inpatients a day on any given day. These are the highest numbers that we have seen since back in July, when we were really at maximum capacity. We have about 1.5% of all of our cases that have resulted in death so far in Alabama. That's fairly consistent with what a lot of other states are seeing. Some are unfortunately even worse than that. Just to remind you, 1.5% seems like a low number, but that's about 15 times the death rate we see with influenza. And 1.5% of 4.9 million Alabamians, that's about 75,000 deaths. That 75,000 is a number bigger than all but about 6 cities in our entire state. That's what we might expect if everyone in our state were to become infected. So this is a time for people to be vigilant. This is a time to be careful and to think about what you're going to be doing. Please think about taking responsibility for your behavior so that you don't inadvertently infect someone that you're around. Holiday times are difficult because we all want to be together with our family. I want to be together with my family, but we have made a determination that we can't have the normal kind of Thanksgiving we would do that involves people from different states and multiple generations all getting it together in the house for a day or two. It's just not practical, and we're not going to do that. My wife and I are going to stay home on Thanksgiving, just the two of us, and if we're able to see family, we're going to have to figure out a way to do it safely, one person at a time. And not even clear that we'll be able to do that. For those of you that are going to travel, please do everything you can possibly do to keep yourself and your loved ones safe. That we don't want this to be the last ever Thanksgiving for someone in your family, like your parents or your grandparents, particularly when prevention of disease is so preventable, if we can only do the things that we're supposed to do. What kind of Thanksgiving we have is going to go a long way to determining what December looks like. What's our holiday season going to look like, and what kind of numbers are we going to be seeing then? What situation is our hospital going to be in at that time? Are we going to be here a month from now trying to have this same conversation? I really, really hope not. We have some particular guidance around Thanksgiving, and we have published that, but I really wanted you to hear from Dr. Mary McIntyre, who's the Chief Medical Officer at ADPH, who wanted to give us some specific comments around Thanksgiving and the holidays. Dr. Mack.
Hopefully you can hear me clearly. I'm not going to take my mask off. I'm one of those people that fall into the high-risk categories we talk about. That really needs to avoid being with other people during the holidays, especially if they're not in the same household with them. I've shared information with my family and friends, and also with my church pastor, to make sure that we understand what are things that we can do to protect ourselves. So I'm just going to share with you what I shared with the pastor, and he announced on Sunday, and it's specifically dealing with what my plans are for the holidays. Normally, everybody comes to my house. A normal Thanksgiving for us is anywhere from 15 to 20 people, and that's within the house, and that doesn't include the ancillary friends that drop by to get a plate, okay? This Thanksgiving, what we're doing is limiting the total number to under 10, and we're only adding one household that's not within my house. We have 4 people. We're adding 3 additional folks for a total of 7. And when that additional family, which consists of my son and his wife and his child, when they come through, they know that they have to have on a face covering. We have a thermoscan thermometer at the door that we check temperatures with, and there's hand sanitizer available when you enter the door. They will keep on their face coverings until we can get people separated where they are more than 6 feet apart. But we have the sitting arrangements where we will actually have our household that would live within the house 4 and another table set up for them with 3, but we can all see each other. The plan is that once we've done the initial screening, that we will ask my oldest daughter setting up a Zoom video conferencing for the ones that are in another state and the ones in North Alabama so that we can all see each other. We're trying to coordinate our dinners to eat around the same time. And what we normally do on Thanksgiving is we do what do we have to be thankful for round with everybody, and that includes the children doing it. And at the end, my husband always prays and does the blessing for everybody. The plan is to do the same thing, so we're trying to work through that via Zoom. I will do the serving. Normally, everything's set out with the burners going to keep everything hot. And everybody serves and themselves and gets what they want repeatedly. We will not be doing that. I'll be doing the serving, so there's only one person handling the utensils to reduce the risk of spreading infection. And I'm really careful about how I interact with other people and that I maintain face coverings at all times when I'm out and about, where I cannot maintain a 6 feet or distance. And even when I can, my boss will tell you that I put myself in a corner. If we have a meeting in the office, I'm away from other people. I also do a lot of stuff via calling in. And what we will also do is make sure that once that's done, that we also have paper utensils, cups, and plastic or paper when it comes down to anything that's disposable, so we won't have to be worrying about trying to wash and potentially cause issues with infection. So separate tables, one of them is actually we have the ability to do outdoors if we need to move there if the weather permits it. And that's something we would recommend for people to do. There have been several folks that have done interviews with not just home health officials to try to see what we were doing, but also with others to try to get the message out. And that's why we need you to spread the message that if we want to live to see another Thanksgiving, and I do, that it may mean stepping back this Thanksgiving and limiting the number of people and some of the things that we do. Now is not the time to get out to do Black Friday shopping. And you all have seen where they've also been spreading out so that you didn't have just one day so that you can get bigger crowds. But there are recommendations on the CDC website. And for anybody who needs that information, there are actually handouts and stuff on CDC's website about what you can do and recommendations of other things to do that will allow you as a family to still be able to communicate. And that's where we are. So people, we want you to remember that this is one Thanksgiving, hopefully out of many to come, that we may have to make some changes and should make changes for this holiday season. But that is to allow us to hopefully have many more in the future. And that's it. Thank you.
Thanks, Dr. Mack. Ladies and gentlemen, we're not going to get a do-over on this, all right? This is a big national holiday, and we're in the middle of a pandemic, and our numbers are worse than they have ever been during this entire response. Please be careful. Please be safe, and please try to take care of those people who are most vulnerable. those people you know who are seniors, those people who have chronic health problems, those people that you love and care about. You're not going to get another chance to do this over. I wanted to take just a few other minutes just to update you on a couple of other topics. The vaccine effort continues. As you know, we've had some very encouraging news in the past couple of weeks related to vaccines. We have the first application for an emergency use authorization submitted to the FDA. That was done by Pfizer on Friday. The FDA has said they expect to take about 3 weeks or so to evaluate that, between 2 and 3 weeks to evaluate that. Once that approval is granted, Operation Warp Speed will begin shipping vaccine to Alabama right away, even though there will still be another step or two. The Advisory Committee on Immunization Practices will still need to review the vaccine information and make their recommendation. But while they are doing that, vaccine will be on its way to Alabama already at that time. We are working with a number of places that are able to receive and store the vaccine until we get final approval to use it. We expect that we will get good news from the FDA and the ACIP based on what we know so far. If we get the recommendation that this is a safe and effective vaccine, then we will begin administering it just as soon as we possibly can. I intend to take the vaccine myself. I'm not high priority on the list. There'll be a lot of people who come before me, but when my turn comes on the list, I certainly am confident that if it is approved in this manner, it'll be safe for me to take, and we expect that it will be effective. We have a plan on what our prioritization looks like on who will get the vaccine first. As you know, it is going to be a scarce resource at first. There are going to be limitations on who can receive it and where it can be stored based on the cold chain requirements and the storage and handling requirements. And there also will not be that much of it since the first batch will be distributed all around the country. But all states are prioritizing healthcare facilities and healthcare workers in order to preserve that critical infrastructure of our healthcare system. We will include first responders of many types in that as well, all within our very first phase 1 response. Also part of phase 1, after we begin addressing healthcare workers, we'll include those people who are most at risk for serious complications, those people with certain comorbidities and diseases that put them at high risk for illness or death. So we'll be distributing that information to you a little bit later this morning on what exactly the priority groups look like. We do know that the ACIP will be probably issuing some recommendations on what they think are priority groups, and so we may end up fine-tuning that a little bit based on that guidance, but we'll keep you updated on that. I also wanted to mention to you that we do have a therapeutic, a monoclonal antibody drug that we began receiving last week in Alabama, and that has started being distributed around the state. It is a drug from Eli Lilly, and you'll have to bear with me when I read it to you. It's bamlanivimab is the name of the drug. It was a drug that Eli Lilly produced, and then HHS bought up the first batch of that and is distributing that all over the country, much like the model we had with remdesivir back in May and June, if you remember that. We know that several hospitals have already begun using this drug, although it is designed for outpatients, but it tends to be administered in the hospitals because it's an IV drug, and that's a place where people can go and get that. I know that it has been used here in Montgomery already, and apparently with good success. We expect that around 60 or so hospitals, let's see, wait, let me make sure I got that number correct. I'm sorry, around 40 hospitals have placed orders and will be receiving that drug in the next 3 days or so. So that's all the prepared comments that I had, but be very happy to answer any questions. Please let me just close by reminding everyone, be safe. Please think about those people around you, those people that you care about. Please make sure that if you're going to do Thanksgiving in a group, that you do everything as safely as you possibly can. Thank you. Yeah, Kim.
Dr. Harris, you talked about a mortality rate for COVID that's about 1.5, which most people might say, oh, that's pretty low. Can you discuss that mortality rate for older generations that might be present at Thanksgiving?
Sure, that's a great point. So again, 1.5% mortality may sound pretty good, but not, first of all, not when you apply it to large populations of people, right? As I said, we have almost 5 million people in our state. losing 1.5% of our state would be 75,000 people. And that's just a number that's too big to imagine. But in people who are particularly at risk for serious disease, like seniors, the mortality rate is significantly higher than that. For people over 75 years of age, it's around 20% mortality. And so it's much more significant. When we think about a holiday situation and it's Thanksgiving and you've got multiple generations there and you have parents and grandparents, you're going to have some people who are just simply not going to do well should they happen to become infected. Yeah.
Could you speak to any numbers that you've been given by the CDC as far as the number of vaccinations that we may receive, and any ethical conversations that you've all had to have with regard to what healthcare frontline workers qualify for this?
Yeah, those are great questions. I will tell you a very preliminary number. CDC has done a calculation, and they're planning to make their allotment to each state on a per capita basis. So we had not known previously whether it was going to be pegged to, chronic disease rates or rates of seniors or numbers of healthcare workers, but in fact, it's going to be a per capita rate. Alabama's first allotment has been very tentatively identified as being around 112,000 doses. That number is not a hard and fast number, and it could change. It could be significantly lower. In fact, depending on what kind of enrollment we see among providers, I don't think it's likely to be higher at this point. But what we do think is that after that first dose, Pfizer will continue to ship doses. They're probably going to be contacting us through HHS approximately weekly, trying to determine new allocations. I don't know whether subsequent allocations will be less than that, but I would expect they would not be as high as the first one right off the bat. But we also think that the Moderna product is going to follow close on the heels of Pfizer. We should have that very soon, and it's hoped that between those two vaccines manufacturers, there'll be around 40 million doses total that become available in the first month or two, something like that. In terms of how to prioritize the vaccine, it's been a very challenging issue. We have met with a number of groups. We've taken input from our stakeholder committee, which is around 50 or 60 different people that we've had calls with over the past couple of months. We have a proposal that we've circulated to the physicians on the governor's coronavirus task force to get their input. They were the same group that helped us making the ethical decisions around remdesivir as well. Essentially, we're trying to identify those healthcare workers that are most at risk for exposure. And so those workers who are known to be working with COVID-infected patients, those workers that are involved in procedures like aerosol generating procedures that put them at particularly high risk, those workers who are involved in mortuary work, which could put them at significantly higher risk than others. And then as we get more vaccine, we certainly recognize that we need to take care of all healthcare workers. Hospitals run not only with doctors and nurses, but they run with people in environmental services and people in the laboratory and people in the pharmacy and every other part of the hospital. So eventually we will try to get to all of those, but we're trying to prioritize those with frontline face-to-face contact that puts them at the highest risk. Yeah.
Dr. Harris, what can you tell us about some of the unknowns about this vaccine, such as the length of effectiveness, and is it effective across all demographics in the same regards of the 90%?
Yeah, those are questions that we just don't know for certain. In terms of the duration of effectiveness, it's certainly reasonable that it'll be effective for months and months. We don't know how much longer than that. As you know, there are some vaccines, like, for example, the measles vaccines, where 2 doses protect you for life in most cases. And then there are certainly other vaccines. Think of the whooping cough vaccine or the tetanus vaccine, where you have to get booster doses from time to time. Compare it to the flu shot, where, because of mutations and because of duration of immunity, you need a shot annually, for influenza. So we just don't know what the duration of exposure is going to be in this particular case. And I'm sorry, remind me of your other question.
The demographics.
Oh, yeah, right. So each one of these vaccine companies designed its own clinical trial, and who the vaccine is approved for use in is determined by the people that they enrolled in their studies. So, for example, we know already right off the bat, that none of these first 3 vaccines have enrolled enough pregnant women or children in order for FDA to make recommendations about use in those groups. Now, they're continuing to try to enroll people, and there are other vaccine products that are trying to enroll those groups, so we may have recommendations soon, but we don't know about those groups in particular. In terms of age differences or racial differences or comorbidity, we think we have a pretty good mix of patient populations that will allow them to extend that to all those groups. But FDA really has got to ultimately determine that. And so what I mean by that, if that's not clear, is if a study doesn't include enough people with, say, diabetes or heart disease, it may be that vaccine is not approved for that particular group. And so the vaccines are not going to be interchangeable. Not every vaccine product may be appropriate for any given person, and you may need to, get one but not be eligible to get the other. Also, the first 3 vaccine products that we know of are going to require multiple shots. They're going to require 2 shots separated by either 21 days or 28 days, and so whichever product you start with is the one you need to continue with. Yeah.
You just mentioned that they're not approved particularly, or they won't be approved particularly for women who are pregnant or may become pregnant. That eliminates maybe half of the people who work in your state's healthcare system. Is that a concern?
Sure. I think that's exactly right. I think we understand that they're not going to be approved for women who are pregnant. In terms of women who may become pregnant, that's an extra step a provider is going to need to take and have a conversation with a patient if they're eligible otherwise to receive the vaccine. Because we're concentrating in many cases on seniors, the seniors who are healthcare workers are going to be the very first of the first. And so that might not be an issue in that group. But in other groups, it's definitely an issue. I don't know, but I expect it will be approved for women of childbearing age as long as they're not known to be pregnant. But we really have to wait and see what that guidance is on that. So, yeah.
Can you talk about the concerns of storage for especially like the Pfizer vaccine that requires really extreme cold temperatures? Is there a concern about, especially for the first inundation of people getting vaccinated, and also about rural healthcare workers? Is there a concern about reaching them?
Sure. So those are great questions. All of the vaccine products so far, as you know, have different storage and handling requirements and different cold chain requirements. And the one there are so many moving parts, it's hard to even keep track of them all. But the Pfizer vaccine in particular has some pretty stringent cold storage requirements. It needs to be held in a minus 80 degrees C freezer. We reached out several weeks ago to facilities around the state to determine who had that capacity. We know of some that actually ended up buying freezers in order to be able to do that. It turns out that many of our hospitals, probably the majority of our hospitals, have the ability to store that. But there are some limitations around shipment sizes. Pfizer is only shipping in increments of 975 doses. And so receiving 975 doses at a time and trying to hold them at temperature and trying to use them in the appropriate amount of time is going to be challenging, particularly as we try to push that out to rural areas or push that out to smaller hospitals that may only have a couple of dozen people who will be eligible. We are working on that plan now. We continue to work with hospitals around doing that. We know there are others in our priority groups, like first responders, for example, who may not be or usually are not hospital employees directly, but there may be other healthcare workers in the community. There may be others who aren't directly healthcare workers, but may be at risk for exposure. And so all those are kind of moving parts that we're trying to juggle to figure out how to get this out. Once we get the Moderna vaccine, the Moderna vaccine can probably be held for an extended period in a routine refrigerator or routine refrigerator freezer, which is nice. The AstraZeneca product also has even better or even less stringent requirements in terms of storage and transport. So once we get those available, it'll be much more easier to ship. Yeah.
Knowing that each vaccine has its own different, as you mentioned, categories that maybe it works better for or not, would you encourage people, if they fit the dynamics of any of these first phase groups, would you encourage them to wait to see if Alabama gets the next vaccine, or just take the that you could get first?
Yeah, I mean, I think the answer is always take the one that's appropriate to take, and you're going to have a discussion with your healthcare provider about that. It's really hard to make a, blanket statement, one size fits all statement about that. Ultimately, taking a vaccine is something that's going to be administered to you by a healthcare provider, and that healthcare provider is the best source of information on that. Yeah. Go.
When we get through those first initial groups of healthcare providers, are there special concerns about getting the vaccine in rural areas where we don't have hospitals, you have high numbers of uninsured adults who may be particularly vulnerable for bad outcomes with COVID but don't have a doctor?
Yeah, that's a major part of what our planning effort is. We certainly understand that not everybody has access to a hospital, not everybody has access to a doctor. We are in the process of recruiting many other types of providers, and including in non-traditional settings, to make sure that we have availability everywhere we need to have it. As we move, particularly as we move into phase 2, we will probably try to find anyone who can be a provider and try to have them enrolled in our program to do this. So pharmacies will be included. Most counties, or all counties, have pharmacies. There may be dental offices that have the ability actually to give vaccines. We've had conversations around that. Community health centers are found in every county, or just about every county around the state. And in public health, we'll be doing immunization as well. And I need to remind you that there's no charge for these vaccines. They're being given free to the states, and so there won't be a charge to people for this. Providers are allowed to charge an administration fee if someone has the ability to pay that, or has insurance that covers that. But no one's going to be turned away because of ability to pay. Mike, did you?
Yes, I know there's no hard date, but it seems like the most recent dates I've seen are mid-December when the first round could be available. Is that, you still pretty much on track for that, or is that realistic?
That's what we think, based on the fact that the EUA application was submitted on Friday. So we, as you may have heard, had CDC here last week working with us on finishing up our plan. We have set a date of December 7th to have everything, finished and ready to go. We don't think we'll have vaccine on December 7th, but it could be within 2 or 3 days after that. But certainly we think by mid-December. Okay. Anybody have anything else? Oh, I'm sorry.
Dr. Harris,
Hey, Brandon.
realistically, can you speak to how long it would take to vaccinate enough Alabamians for us to see a decline in numbers?
I don't think we know that for certain. It certainly depends on the effectiveness of the vaccines, of course, and we're hearing that all 3 of the products so far have, 90% or more effectiveness. The AstraZeneca, at least in one of its dosing regimens, has about 90% effectiveness. The higher the effectiveness, of course, the fewer number you actually have to reach. But I think our goal is to make sure we're protecting all those people who are most vulnerable. We want to interrupt disease transmission so that we don't see new cases, but more explicitly, we want to make sure the vulnerable people are protected. We want to, whatever the transmission rates are, we want to make sure we get this to every person who's vulnerable. So I think that's a good question to ask, but the answer is we're not going to know until it happens, probably. There's mathematical models about what percentage of the population you need to get to. But ultimately, we're going to try to get it to everybody that needs to receive it. In Alabama, if you look at the numbers of seniors we have and the number of people with chronic diseases, that's more than a third of our state. And then when you add, healthcare workers on top of that, a couple of 100,000 healthcare workers, that's another group that we want to make sure we get to. So we're going to continue immunizing until we get to everyone we need to get to, whatever our transmission numbers are.
And can you speak to the upgrade to the GuideSafe app now that it allows integration with other states' information?
Yeah, there was that was kind of interesting news. The GuideSafe app, as you know, developed by UAB using the Apple Google notification technology, has been connected through the Association of Public Health Laboratories to a server that allows other users in other states to also be in the notification pool. And so when people from other states who are using that app travel to Alabama, or if Alabamians, travel to those states, the app will work in those states as well, just the same way that it does here. So it's actually a very neat and clever concept, and it's become a little bit broader in terms of where it can work. Yeah.
Last question for me. In terms of our numbers, you mentioned that we're seeing extremely high numbers. Knowing what we know about transmission rates, looking ahead to December, could you almost assume that what we're working with now is nearly baked in with regard to who's already got it, who may spread it this week, and so forth?
Well, I mean, there's nothing that's irreversible, and people in Alabama have the ability to stop this in the next 2 weeks if they can just take responsibility and do what they're supposed to do. I would say we're really scared about what December is going to look like based on what we're seeing right now, but it's not inevitable. It doesn't have to continue on this upswing. And now's the time to make that you can make a difference. I mean, now is the time to take responsibility. Just stay home, stay away from others who are vulnerable. If you have to get out, make sure you're doing everything possible to keep yourself and other people safe. We don't have to have a terrible December, but I am worried about what we're going to see. Okay. Any other questions? All right. Well, listen, thank you all for being here today. We really appreciate your time. Thank you for helping us to get this message out, and I hope everybody has a very safe Thanksgiving.